And it's a pleasure for me to introduce Dr. Keith Van Haren, who will be presenting on an introduction to supportive therapies. So Dr. Van Haren, thank you for joining us, and please.
Yeah, thanks very much for the invitation, everyone. My pleasure to join the meeting here and present to the group. I'm really impressed by the turnout. There's clearly a lot of, you've got a lot of great community momentum here. So I hope that my slides here can be helpful to the group. I've been asked to present on it's sort of preventive care and anticipatory care, and trying to leverage this this kind of care to improve outcomes. And so I have no disclosures. Here's an overview of our talk. I'll focus on I think a little bit in the beginning and the end. I just want to warn those who are watching, I do have some slides that have a lot of information on them. That information is generally contained in some of the guidelines that have been published, and I can circulate a copy of those guidelines to the Yaya Foundation if they want to post them on the site or circulate with the group. But don't feel like you need to write down all of the pieces you see on the screen. They'll be available either through the slides here or through guidelines elsewhere. So I will skip over some of the details of some of the slides. Just bear with me as we move. I'll try and keep it most tailored to the group. So, but we'll cover some sort of philosophical approaches to care, and some aspects for viewing, perspectives on looking at preventive care and family-centered care strategies that can help improve the experience and potentially the outcomes in care. Okay, so this is I think for many people who arrive at a diagnosis of a genetic disease that is very rare, there's a period at least of some hopelessness, and they say, oh no, there's no treatment in quotes for my disease, and what can I possibly do? And this is I think a counter argument to that. So one of the genetic diseases that was identified kind of early in our current era of medicine was cystic fibrosis. This is a disease of the lungs that was long considered and remains incurable in the classic sense, meaning there's generally no definitive treatment that eliminates the disease forever. But despite that, and despite many complications, life expectancy has increased tenfold over the past 60 years. And that's without this so-called cure, right? So keep this in mind. And a good question is how has the cystic fibrosis community done this? Well, they've done it by leveraging a whole series of incremental steps that targeted things like reducing lung infections, improving lung function, increasing clearance of mucus in the lungs, and fixing each of these pieces one at a time. And many of these were quite simple. Some were cheap. Many were already existing, and some were not even pharmacologic in essence. And so this is prior to the era of gene therapy or for this disorder that is coming for cystic fibrosis too. But I would take this as an inspiration for any community of rare diseases. Okay, and that's part of the inspiration for this talk. So specialized centers for cystic fibrosis really do appear to provide better outcomes, and that's because they have specialists, doctors, therapists, and others who are really familiar with the disease and the possible complications, and are often very vigilant about anticipating problems and preventing them before they occur. And as I think is evident in the approach with, sort of like the vaccine versus the treatment for a disease, right? Preventing a complication is generally preferred, always over just treating a disease once it has occurred. And so we can't prevent the genetic changes for many of the rare genetic disorders at this point, but we can treat some of the complications of these or prevent some of the complications from manifesting to some extent. So, there is a process here which we're producing guidelines for every leukodystrophy. And so do we have specific guidelines for every leukodystrophy? Like, do we have specific guidelines for 4-H syndrome yet? I'm sure they are in the works. They may not exist in a formalized form yet, but you will probably have some specific guidelines, and there are some specific strategies for 4-H. There are some disorders that are, were discovered earlier in the leukodystrophy, process of exploration back in the, 70s and 80s, and those would be ALD and MLD and Krabbe, and those do have some specific strategies attached to them. But many disorders in the leukodystrophy realm, including 4-H, have a lot of overlapping symptoms, and we can group some of these symptoms and complications together and say, well, listen, lots of these disorders are sharing similar complications and outcomes, so maybe we can think of them more broadly together. And that's, there's a long list of things that can affect many patients with leukodystrophies. These are not true of all leukodystrophies, okay? So for 4-H syndrome, there may not be aspects of each of these pieces, but it's kind of a long list of things that we can at least put on our list as physicians and as parents of things that we might think about, and in the long term, target for prevention and or improved treatment. So many symptoms are shared, and currently our practices are getting better. I think they began in very irregular fashion. I think Dr. Bernard and others are really leading the efforts to standardize these care practices, and so these are really improving. And some problems are foreseeable and preventable. We can treat seizures and we can prevent seizures. The neurology community has spent a lot of time and money over the past 50 years developing seizure treatments, and so we can do a lot in this realm. And then there are complications that are often quite predictable, particularly aspiration pneumonia, pressure sores, constipation, dehydration. These are things we can look ahead for and potentially prevent. So years ago now, we set forth to put together the first consensus statements on preventive and symptomatic care, and this included some of the people giving talks today, including Dr. Bernard, and we followed this up a few years later with a subsequent update that expanded further on some of these ideas. And it begins with a basic philosophy that even though leukodystrophies are incurable in the classic sense, what we might say with bacterial pneumonia, we can cure bacterial pneumonia. We can give medicine and get rid of it at least forever in one sense. But that's dramatic. But for the leukodystrophies, of course, with a genetic origin, they're more complicated. And so leukodystrophies, though, share, they are all have treatable symptoms, and we can target some of those symptoms, including pneumonias, and we can try and treat and prevent those complications, because in effect, those are the things that, many of those things actually are the problems that make life challenging for people with chronic disorders. And we can support also emotional, social, and the economic health of families. And these are all things we can do without a so-called definitive cure. So there are a list of symptoms that are specific to some leukodystrophies. And these would include, they were not specific only to ALD, but or Cardi Gutierrez and others. But this is just a case in point that some disorders do have some unique features, and that does include in some ways 4-H, which is labeled in these slides as Pool 3. And so we can think about these things together at this point as just pieces that can occur. I think some of these features are at this point harder to prevent entirely. But for instances where we have hormone deficiencies, such as in 4-H, we can try and replace some of the hormones with oral medications. And for dental anomalies, we can target preventive care to try and improve or reduce cavities and certainly reduce pain events associated with dental cavities or other complications. But more often what we have are symptoms that are really shared across the leukodystrophy spectrum. And these include cognitive delay, constipation, dystonia, which is sort of like muscle stiffness. It's a similar to spasticity in many ways, but the clinicians are expert in determining what is spasticity and what is dystonia as best we can, and we have different treatments for those symptoms. But we can target some of these symptoms, and they can alleviate pain in many cases, and they can also improve quality of life, such as identifying source degrees of cognitive delay to try and develop adaptive strategies to help children communicate, to help children learn, to help target emotional, intellectual engagement at their level. These are really important things that can make the life of a child and a family much, much better. And in some cases can be done with little risk of medical side effects or others. In the case of learning and adaptations and adaptive communication devices. In the cases where medication is needed, such as with dystonia, it does get a little bit more complicated. Each of these every time we're adding a medication, there are likely to be side effects of some kind, and some are minor, some are more major. But anticipating these is important. I will say I spend a lot of time with families trying to help them access specialists who can work with adaptive and augmentative communication devices. I think this is time well spent, because as any of us can imagine, just in simple conversation, when we feel like somebody isn't understanding what we're saying, our frustration level rises really, really fast. So if we feel like we're trying to say something and somebody isn't listening, I think we can probably relate with our children, for example, or if they're misunderstanding what we're saying, we can all feel our frustrations level rising. And our children, no doubt, feel exactly the same way. So helping children develop clear and easy communication strategies is I consider a major priority for families and kids. And in some cases, it can really alleviate kind of outburst behavior for the kids, where kids go from having lots of outbursts, being really upset all the time, to suddenly, now that they have a way to communicate, they're really feel like the teachers feel like they're engaging more in class, the parents feel like they're having fewer emotional outbursts at home. And I think if we take our own experiences and consider how frustrating it is when we can't communicate, it's easy to understand how kids might react similarly. So I recommend doing this, and I think trying to even start with a simple yes/no for kids who have really severe disability is the place to start. I spend for kids with really severe impairment, I do spend a lot of time just trying to help families identify a simple yes/no strategy. I know that sounds like maybe simple or basic advice, but it's really important. Once a child loses the ability to even say yes/no, then life changes dramatically once they lose that ability. So starting with yes/no and then building from there and finding a dedicated specialist, usually a speech therapist, who can help with adaptive augmentative devices and is creative and persistent in working with families, can really make an enormous difference for kids. Motor delay, spinal curvature seizures, salivary, this is drooling. These all have targeted therapies to some extent that can be targeted. Each of these is, the goal here for each of these is not always just to achieve one notch in the, of this or that. I think if it's important to sort of always take a step back, and when you're feeling frustrated of, oh, we're not getting, my child isn't, let's say walking at this as soon as I want them to, or are they going to walk and so on. Try and take a step back and say, well, what does walking do for us? It gives us the ability to go from place to place where we want. It's not really so much walking per se that we all need, although walking is clearly a wonderful convenience to have. The thing that will matter most from the child's perspective is being able to go where they want to go when they want to go. And so providing, maybe if you're not hitting the goal that you want, the walking or the certain hand movement, try and figure out what the end goal might be with, from the therapist or the child's perspective, and think about maybe a more adaptive solution. So if you're not hitting the walking goal, maybe some other adaptive device, even wheelchair or other motorized device, might be useful in achieving the goal of just, mobility independence. And I would say try and think about things practically, try and be flexible, and try and always periodically take a step back when you feel you're getting frustrated with either lack of progress or a setback of some kind, and say, well, what is it that really matters here? And for many of these things, there are bigger pictures we have in mind. So for seizures, for example, frequent seizures can impair the ability to sort of engage in learning. And so counting individual seizures that are very short may or may not be so important, but making sure you're preventing prolonged seizures, admissions to hospitals, due to seizures, things like that is maybe the most important thing. For drooling and other such things, I know there are some talks on each of these later, and so I won't delve too much in here to some of these details, but the goal here is to sort of balance cosmetic and social concerns with medical needs and the risks of side effects of treatment. So again, to totally normalize oral secretions isn't always the most important goal, but to try and make life better, easier for the child and for caregivers is part of the picture. I'm gonna move on past some of these because I know there are some people discussing these points a little later on, and we'll just try and keep to some time here. And I want to talk about some issues that are, I think, good for targeting for prevention. And I want to raise the specter of anxiety and depression in kids with impaired communication and impaired cognitive function. This can be really hard to identify, but I think that we're probably way underdiagnosing this in many children with special learning needs, and that some of the behavioral disturbances, some of the malaise and others may actually be symptoms of anxiety and depression. Figuring that out is really challenging. It's beyond my capabilities in those cases. I think finding psychiatrists who have the capability to do this is also challenging, as psychiatrists are stretched thin as it is. But I think this is worth talking about with your specialist and considering on the list of things that you might wonder about, of a change in functioning level, a change in engagement, a change in mood or affect. This would be one of the possibilities to consider. And I would put chronic pain right there next to that. Sometimes, again, when there are kids with impaired communication, chronic pain can go undiagnosed for a very long time. It can dramatically impact the life of the child and the family. So having I would say the most important thing here is having a medical team who is really dedicated and persistent in trying to figure out, kind of sleuth through each problem or concern, and consider a range of possibilities. So for chronic pain, there can be a whole bunch of drivers of this, and they would include, but near the top of the list would be constipation, dental pain, urinary retention, joint fractures and dislocations. These, I think, keeping a list of these in mind as a parent of causes of pain is a good one. And maybe running through this list when you feel like your child is having problems, of having your checklist of, I think my child's in pain. Could it be constipation? How can I figure this out? Are they having regular bowel movements? Could it be dental pain? What is, how is can I inspect their mouth? When was the last time they saw the dentist? Could it be, urinary retention, urinary tract infection, and so on? Having a list like this just to run through is very helpful. It's a checklist, so to speak. For pneumonia, both community-acquired and aspiration pneumonia. So I'll say up front, this is the most dangerous thing for children who are mobility impaired. These are the things that are most often fatal, or the most cause of morbidity and mortality in kids with impaired mobility. There are a long list of reasons for this, but not being able to move around and take deep breaths, exercise, and so on greatly increases the risk of lung infections. Not being able to swallow regularly increases the risk of lung infections, or swallow correctly. These and recurrent lung infections can increase the risk over time of future infections of the lungs. And these are, I would put forth as really important targets. Do we have the ability to prevent them quite yet in leukodystrophy community? I don't think we have great or perfect strategies for this. I think being aware of it and diagnosing these things early when possible is important. And we are working on trying to identify preventive strategies for this. I think just keeping this as part of the discussion, trying to maintain good oral hygiene and good lung care with a dedicated pulmonologist is important. So, okay, pressure sores and wounds for kids who are mobility impaired and or have diminished sensory function. These can manifest, particularly with orthotics in place. So small sores can be the source of pain and also infection. So keeping a close eye out for these is important. Urinary tract infections can go undiagnosed for long periods of time. Women girls and women are at high risk. And I would, be sure, consider asking for a urology or nephrology consult, after maybe the second or third UTI in females and first UTI in males. So malnutrition, I think others will speak to iatrogenic sedation and polypharmacy. This is that's fancy words for too many medications causing sedation. I think this is a friend of mine for many parents, but this really can happen. There is a balance of finding the right mix of medications to treat symptoms that matter, and then not using too many medications to treat symptoms that maybe don't matter or don't need to be treated as aggressively. And finding that balance is often a conversation. Joint fracture and dislocation. This is a really tough problem. I would say fractures are the most important priority to identify and treat. Dislocation is a more complicated scenario in that chronic dislocations, there is, I guess, some uncertainty about whether they're the source of chronic pain or not, and that may vary from child to child. Some chronic dislocations, I'm told, may not be the source, may not always cause chronic pain. So I would, again, this is a conversation with your treating team about how to identify and treat these. Treating dislocations is sometimes we don't have just putting the bone or the joint back in the socket is it's not always a long-term fix and isn't sometimes worth the extra pain involved. So I think that's a conversation with your provider team. So the health, the family and child. So this is a call out essentially to you know, all of those who fly in the airplane are familiar with the phrase, you know, case of emergency, apply oxygen to yourself first. This is the same principle here. We really have to take care of ourselves as caregivers. And you may know that caregiver stress is uniquely severe. So caregivers for any adult or child with chronic illness have extraordinarily high stress levels. And I think making the self-care a part of your child's care routine is really important. But your child does really depend on you for their care. That's a reality, and it's also a very heavy burden for parents. Just the knowledge that your child is dependent on you for and is likely to be for a long time is very stressful. And then just all of the things that care requires is really stressful, and it's very hard on parents. It's very hard on marriages. It's a common cause of can frequently cause depression, and it is a really challenging thing to deal with in terms of sibling dynamics. So the idea of sibling neglect, one child feeling jealous or feeling neglected by the attention that their other sibling receives is real and I think quite common, and is worth keeping in conversation. Financial hardship, over medicalization of care, medical exhaustion. These are also things that can come with the process. Again, this I would say that for the latter two, trying to keep the big picture in mind of when to step back and say, what's our goal here? What is our goal with this particular strategy? We're using this medicine for this symptom. Is this symptom so severe that we need to treat it with a particular dose we're using, or can we scale back? Are there other medicines we could try? Is this still worth, treating given the side effects here? Again, these are lists of things to keep in mind when you're revisiting big picture issues with child and family. Okay. And so, having said all that, where to begin? I would, for those of you who are new to the diagnostic odyssey or the care odyssey, a good place to start is to formalize your care team. Figure out who's going to be the quarterback, which is for American football fans. Who's going to be the person who's most in charge and going to kind of synthesize much of the input from many other specialists. In general practice, this is a pediatrician or a family practice physician or a general internist. In our cases with rare diseases for rare neurologic diseases, sometimes it's the geneticist, sometimes it's the neurologist, sometimes it's the pediatrician, but figuring out who that person is and working together to centralize care around that person is important. I think creating a basic care schedule with your family and your provider where you put on paper when the approximate month you're planning to do all these things is really helpful, because as we all know as parents, the year gets very busy and things can get lost in the shuffle. So putting on paper the really important points, and it's my timer here, so the really important points is key. Don't be afraid to ask questions. I think I think we all understand this, the last one here, more than we used to, thanks to COVID. But staying connected with the community of people is essential for all of us. It's really, really important when you are affected by a rare disease, because you have to find your community. And it won't just be one community, it will be community neighbors, There'll be a community of rare disease teams. There'll be a community of people at school. And that's great to have a diverse set of communities too. So don't, I would recommend diversifying. And if you're finding your community is only online, that's a problem. You need to find a real life community too. And so it's great to have an online community, but it doesn't replace a community in real life. I think that is becoming more and more apparent to all of us. So I will leave these slides up and take questions. And I will just thank those who helped assemble these care guidelines, including Dr. Bernard, over the years, who's led a lot of these efforts.